I'd like to introduce to you our next speaker, our final speaker of the day. Dear participants, allow me to introduce Dr. Arun Kumar. Dr. Arun Kumar has obtained his medical degree, Doctor of Medicine from Gajah Mada University, Yogyakarta, Indonesia. Completing his housemanship in Hospital Teluk Intan, he joined the Psychiatry Department, Hospital Tawau, at the end of last year. He plans to further pursue psychiatry, having recently passed his Part A for MRC Psych. Please welcome Dr. Arun Kumar as he presents Risk Assessment for Suicide and Violence.
Okay, good afternoon, everyone. Thank you very much, Dalili, for that amazing introduction. And congratulations to all our participants for sticking around until now. I'm sure all of you must be feeling a bit full with all the amazing information that was given by our esteemed speakers. So I will try to make my presentation a bit quite simple and direct, and just try to give you the key points you need to know. So this afternoon, I'll be talking a bit about risk assessment, specifically for patients who are aggressive and suicidal. I'm focusing more on the assessment part. So let's begin with aggressive patients. So before we can continue, we should know a bit about what exactly is aggression. So aggression and violence refer to a range of behaviors or actions that can result in harm, hurt, or injury to another person, regardless of whether the aggression or violence is physically or verbally expressed, physical harm is sustained, or the intention is clear. So the range of behaviors can be anything from a hurtful remark to actually using a weapon to intentionally hurt or injure somebody. So why should we care about aggression in patients? It's quite obvious that the impact of aggression and violence is significant, as well as adversely affecting the patient and the others around them. Others around them being not just the healthcare workers, such as the doctors, nurses, medical assistants, but other patients as well, particularly in closed environments or confined spaces such as wards. So it is an important safety issue, particularly in psychiatric patients or patients with certain medical conditions such as delirium or intoxication, as been mentioned previously by previous speakers. So if there was anything you should remember from this presentation, I would like you all to take a look at this, this one slide. So this is what we call the assault cycle. So it displays the physical, psychological, and motor behaviors response to perceived threat. And it consists of 5 distinct phases. Why is this important? Because anytime you see a patient who comes, who appears aggressive, a lot of times there's a misconception that the aggression was spontaneous, that it occurred out of nowhere, out of the blue, and couldn't have been predicted. But as you can see from this cycle, person who becomes aggressive doesn't just spontaneously becomes aggressive. There are telltale signs that occur before it. So the 5 phases are the triggering event, the inciting factor that causes the patient to start, causes the person to start becoming aggressive. This could be anything from a long waiting time, something being said rudely to the patient, and etc., which I'll go on a bit detail later on. So when this triggering event happens, the patient internally has begun the countdown to the crisis, which is escalation. So at this point, the patient hasn't done anything to harm others yet, but it's brewing within. So at this point is when our best chance for intervention is. Before we allow it to escalate further, this is our ideal time to interact with the patient to try to de-escalate the situation. However, if we fail to recognize the signs of escalation at this point and let it go on, it will eventually come to a crisis. And this is when it is at the peak. The patient becomes aggressive, does harmful things, and hurts others or hurt healthcare workers or other patients around them. And at this time is when most of the chaos ensues. This is when people are rushing to restrain, trying to get some medication to sedate the patient. Most of the time, it's either very difficult or a failure because the patient's already in the crisis. But however, if it's managed to contain, the patient eventually will calm down and go to the recovery phase where he'll slowly cool down, become less aggressive. And then in some cases, after they have cooled down completely, they realize that at that time they were probably acting out of proportion and may go through a post-crisis depression. So, what are the signs of escalation of motor behaviors in the assault cycle? So usually after the triggering event, the patient's body language is the first most obvious sign. So their appearance might change. A patient who maybe previously was calm suddenly will have clenching of jaws or hands. They'll be frowning. They'll be visibly upset or anxious. Their speech, when you talk to them, becomes loud, sarcastic, start swearing towards healthcare workers or other patients with exaggerated movements or pacing and a more demanding or hostile behavior, which if we don't intervene timely can further escalate to a more fearfulness or angry appearance. Speech becomes more belligerent, shouting, rambling. Movement is making fists, pounding, and then threatening, throwing items, all of which, again, if we do not take any measures, will end up in rage, our crisis phase, which is when the patient is at the highest risk of hurting somebody. So within that period of the triggering event to just before rage is our window of opportunity to step in. So as I said, we have to be mindful of the risk factors for aggression. So risk factors can be broadly separated to 3 points: the demographic or personal history, the clinical variable, and the situational variable. So the demographic or personal history. So when dealing with a patient, especially when you suspect that there's a chance for aggression, you have to consider, has the patient have any history of disturbed or violent behavior in his life? Any history of misuse of substances or alcohol? Because we know substances can induce mood or psychotic symptoms, which may worsen aggression, which may cause aggression. The carriers themselves reporting that the patient previously has angry or violent feelings, or the patient himself previously expressed by themselves that they intend to harm others. That is a very telltale sign, or any previous use of weapons, as well as previous dangerous or impulsive acts, the severity of the previous acts, or the patient previously has done something that is dangerous, but they deny it completely when you question them. So they're trying to hide from you, as well as the verbal threat of violence, or any evidence of a recent severe stress, such as a loss of a loved one, or the threat of loss of a loved one. That may cause some people to feel angry as well. For the clinical variable, for medical factors, of course, any recent trauma or injury can cause altered state of mind, which may cause the patient to act aggressive. And this is more in line with the delirium, as our Dr. Fahana has spoken earlier. So delirium has many underlying causes, and all these causes can cause the patient to act disorganized, inattentive, and aggressive. So the treatment to that, as Dr. Fahana spoke previously, is we treat the underlying cause, and the delirium and aggressive behavior will be treated as well. So these are just a few examples: intoxication, overdose on prescribed drugs, especially the anticholinergics, and some infection causes such as meningitis, encephalitis. Some more common causes: hypoglycemia. Even though mostly we associate that with a patient with low GCS clinical state, sometimes hypoglycemia can cause patient to become unnecessarily aggressive, as well as hypoxia, hypertensive encephalopathy, or Wernicke's encephalopathy. Several other causes such as temporal lobe epilepsy, dementia, poorly controlled pain, and neoplastic conditions. And also, we cannot disregard also that some certain psychiatric illnesses do present with the patient being aggressive. So these are mainly the active symptoms of schizophrenia or mania, in particular hallucinations or delusions focused on a particular person, commanding hallucinations where the auditory hallucination commands the patient himself to do violent things, which is a very important sign that you should get during a history taking, or preoccupation with a violent fantasy, or delusion of control. So the patient feels that their body is being controlled by something external, commanding them to do something violent, as well as agitation, excitement, or overt hostility or suspiciousness to a particular person or everyone around him. The clinical variable also includes the patient factor. So maybe normally a patient who is warded probably feel like they're not in control of one's own situation, not feeling respected. If they're still recovering from whatever underlying medical problem, they might still have a confused state and they feel frustrated with inability to communicate effectively, which may cause them to act out in fear or anger or anxiety. This including feeling that their one's personal space or property is being invaded, feeling overwhelmed by information or lack of information, a past experience of being rewarded for violent behaviors, as well as antisocial or impulsive personality traits, which also should be kept in mind. Environmental factors such as unpredictable routine or structure, an institutional rather than a homely environment, overcrowding, high noise levels, poor air quality. This can be said in some of our wards also. Some of our wards are quite crowded, not very spacious, quite confined. This kind of unfamiliar environment can cause patients, especially delirium patients, to be aggressive in the ward because of this. So that's why when we're treating patients with delirium, we have to make sure they have adequate lighting, a caretaker to frequently reorientate them, and always making sure their needs are met. Other environmental factors include inadequate nutrition, too little or too much stimulation, lack of personal space, possession or access to a weapon, or if in outpatient, long waiting time in outpatient setting. For the healthcare provider factor, so more of our roles, normally people with junior staff with untrained to how to handle aggressive patient, sometimes they tend to panic at that time about how to deal with the aggressive patient the best, which may cause the aggressive patient to escalate, or poor leadership or inadequate staff resources. Another thing is sometimes our own attitudes towards patient. Sometimes, a busy day, too many patients, we can't make everyone happy. Sometimes some patients are forced to wait, but because of that, we tend to not listen to their needs very tentatively, because we're busy, we have other things to do. But some certain patients, they can't accept that. So by ignoring or being indifferent to these patients, they may inadvertently escalate their already bubbling anger to our healthcare workers, or refusing any fair requests from patients, force or perceived as forcing the patients to take medications, even though we're giving it accordingly and even nicely. Sometimes they're perceived that, oh, we're just forcing them to take medication that they don't need, or ineffective listening skills. So a patient might ask a question, but in the pursuit of efficiency, probably we just answer very briefly and then move on, but the patient doesn't feel satisfied with it. So even small things like this can cause someone to feel angry. So we should really take the time, especially if we know this patient has a tendency to be aggressive, to just be a bit more patient with them. As well as exercising a bit rigidity, lack of opportunity for negotiation. Okay, so This is an example of a risk assessment of violence used in HKL. So this is more of a ward scenario where a patient who maybe is showing aggressive behavior. It's a little guide to how we can handle them. So in the risk factors, we have high and moderate risk factors. So for high, such as command hallucination, provoking behavior, restless, and uncooperative. And moderate is increased tone, verbally abusive, hostile looking, and persecutory delusions. So throughout the day, chart how often these symptoms appear and then document accordingly. So to determine the risk and intervention, so if there's more than 2 high-risk factors or only one factor with the star, which is command hallucination or provoking behavior, it's best to ask the doctor to review, initiate assault caution, and consider for parental sedation if needed. Preferably bring the patient closer to acute day so we can monitor their behavior, and also BD review, but this is more of a guide. If you feel the patient is even more aggressive, more frequent reviews may be needed. If there's a moderate risk factor of 2 or more risk factors, more or less inform the doctor review, sought caution, and if the patient at that time is not has not escalated too much, we can still offer the patient oral sedation, something to calm him down at that time. Then continue observation as well. Another assessment tool we can use is the Broadset Violence Checklist. So it's just a useful instrument in predicting the violence within the next 24-hour period, which is even a bit more simpler. It just includes symptoms such as confused, irritable, boisterous, meaning loud, noisy, disruptive, verbal threats, physical threats, and attacking objects. So each is called 1. And so if there's 0, the risk of violence is small. 1 to 2, the risk of violence is moderate. Preventive measures should be taken. And if more than 2, the risk of violence is very high. So more immediate measures should be taken, like parenteral medication or increasing the dose of this sedative medication that's already on. Okay, but just keep in mind, all these assessment tools are just a guide. In the end, the biggest and best assessment tool is your own clinical judgment. If you feel the patient is getting aggressive and needs medication to calm him down, then it's a doctor's duty to carry out his fault. Okay, that's for aggressive patient. Now we move on to suicidal patients. So in suicidal patient, the thing we would like to stress on is the assessment part, is what are the questions you should ask and how we should ask them. It's because as this image shows, if you can just ask the patient, person, are you okay? And I'm fine, but not really understanding the deeper problems that are going on through. So this is just a collage of images of famous celebrities, all of which have succumbed to suicide due to either drug overdoses or depression. So they all appear happy on the outside, but the deep troubles within them is something that they conceal very well. And this is what, as a attending doctor or nurse, if you see a patient that appears suicidal, we have to make sure that we probe and dig as much as we can to make sure we don't miss it. So a few definitions. So suicide is defined as a self-inflicted death with evidence that the person intended to die. So it's self-inflicted with intention to die. Whereas a suicide attempt, it's a self-injurious behavior with a non-fatal outcome, accompanied by evidence that the person intended to die. So the patient wanted to commit suicide, but was unable to complete it. Whereas a near-miss suicide attempt is a potentially self-injurious behavior with the evidence that the person intended to die, but stopped the attempt before any physical damage occurred. So the patient was on the cusp of attempting to suicide, but stopped right before it. Whereas suicidal ideation, it's thoughts or serving as the agent of one's own death. So this is something we'll will touch upon a bit later, but this is where it's a bit of a gray area. So how serious is the suicidal ideation causing to that may lead to suicide is what we need to probe further on, which I'll share on a bit later. The other is suicidal intent, which is the subjective expectation or desire for self-destructive act to end in death. So this is the intent when doing a behavior that is self-injurious. Is was the intent to end in death or not? And finally, non-suicidal self-injury, which is a direct, deliberate destruction of one's own body tissue without any intention to die, such as cutting or burning one's own skin. So this is a direct, deliberate attempt to injure themselves, but without any intention to die. So most people, some patients who do this is because of a coping mechanism. Normally they go through a stressful event and they need to release the stress. They don't know how to properly release it. So they cut themselves as a means to release the stress with no intention to kill themselves. Okay. This is just a simplified graph of what was the previous destination. So high intent to die, which results in death, is a suicide, whereas a high intent to die with just sustaining injury is just attempted suicide. Whereas low intent to die, which just cause some injury, is just self-harm. But sometimes people have low intent to die, but result in death. So this is a accidental suicide. They tend to just harm themselves, but harm themselves more than the body is able to tolerate until it led to death. So suicidal clues. So suicidal clues can be broken down into four categories. So verbal, with direct or spoken or written statements such as "I am going to kill myself." Behaviors that hint at suicide, such as purchasing a gun. Situational, such as life-changing events such as death or divorce or newly diagnosed terminal illness or losing one's job. And finally, symptoms syndromic, which are symptoms associated with suicide such as depression, hopelessness, and loneliness. So the risk factors that increase likelihood of suicide is prior suicide attempts, misuse of abuse and alcohol or other drugs. Frequently, patients take alcohol or other drugs to get them to a state where they feel they're disassociated enough to actually attempt it, disinhibited enough to attempt the suicide. Certain mental disorders such as depression and some other mood disorders as well as access to lethal means such as a gun or poison or certain medications, as well as social isolation, chronic disease and disability, lack of access to psychiatric healthcare, prior history of trauma, as well as their own impulsivity and poor self-control. So these are the risk factors. But at the same time, we should identify protective factors that can help the patient cope with their suicidal thoughts. This can be either internal or external. Internal including good coping and problem-solving skills, positive values and belief, ability to seek and access help, spirituality, how strong is their religious belief, capacity for reality testing, reasonable frustration tolerance, as well as hopefulness and optimism, and also their fear of suicide. Whereas external protective factors include strong perceived social support connection, good family support, good friend support, having children or pets at homes, religious prohibition, positive therapeutic relationship, if we are dealing with a patient and doctor relationship, sense of responsibility, receiving mental health care, and fear of social disapproval. So in any patient, when dealing a patient who is suicidal, in addition to identifying the risk factors and trying to minimize it, we should try to identify the protective factors and prop up as much as we can and try to involve as much of these protective factors to help the patient. A few general considerations. asking about suicide will not make the patients become suicidal. This is, I think, quite a old myth in mental health, where it's best not to talk or ask patients if they're suicidal because they'll just give them the idea. No, most of the time, talking and sharing and discussing suicide will help the patient vent, release their frustration, understand better the state of mind, and actually reduce suicide. But the key is to set the stage for the questions and to signal to the patient that the questions are naturally part of the overall assessment of the current problem, as well as asking the questions in a caring, concerned, and compassionate way. When you do this, it helps us to establish a good rapport so that patients are more open to talk to us. So a few do's and don'ts for establishing rapport with a suicidal patient. So do engage with the patient, be responsive to what they say, active listening, and don't is to do not be judgmental. Sometimes suicidal patients may say things that we ourselves feel is not a reason to commit suicide. But to them, it's serious enough that they're thinking about this. So we cannot bring our own prejudices into it. Be respectful, professional, and be empathetic. This takes it's a practice to be all of this. So the more suicidal patients you see, the better you'll be able to carry this out. As well as do not be shocked or embarrassed or panic when a patient says suicide. A lot of times when you hear the patient, oh, I want to commit suicide, we tend to be a bit hesitant to ask what's next. What do we ask next? Because we don't want to say the wrong thing to worsen the patient's situation. But just calm yourself down, take a step back, and then start probing a bit further, slowly. What happened previously that causes the patient to want to commit suicide. And related to that, don't make the problem appear trivial, and don't try to cheer the patient about making jokes about his suicidal thoughts. So the factors that need to be assessed is the current mental state and thoughts about the death or suicide, current suicide plan, how serious is the intent, or what's the methods, as well as the person's support system, family and friends that can help the patient with whatever problem is going through. Okay, this is just a small slide to just show the various risk factors and warning signs. I think I'll just pass this over. It's more or less a conclusion of what I said previously. Okay, so now go on to some of the assessment scales. So this is quite a common one, especially used. It's called the sad person scale. It's quite a straightforward scale. It basically includes various risk factors, which includes sex, age, less than 19 or more than 45 years old, is a person having depression, any previous suicidal attempt, ethanol or alcohol abuse, rational thinking loss, social supports lacking, on organized plans, no spouse or sickness. So basically, a patient comes to you and say they're suicidal. This quick screening test can help you evaluate. If the score is less than 2, you can discharge the patient with outpatient psychiatric evaluation rather comfortably. But however, the score is 3 or more, maybe you can consider hospitalization or a psychiatric referral at the very least to make sure that the patient is not in crisis and is actually about to attempt their suicide. This is a very quick and fast way to assess a patient's suicidality. Or we can go on to back suicidal intent scale. There are various ways to assess assess suicidality in a patient. This is one of the examples. It's a good example because there are various questions that you can ask in your clerking to get more information on just how serious is this person's suicidal intent. So the first is isolation. So basically means if a patient does their suicide attempt in a secluded place away from people with no chance of them noticing the person, anybody noticing the person. So the score is rather high, 2. So no one nearby is visual. Whereas if they did it at home with the door open, with family around, the isolation score would be 0. Same thing with timing. If they did it in such, if they plan to do their already done their suicidal attempt in a place where intervention is highly unlikely, such as an isolated place, then the score would be higher, as well as precautions against discovery or interventions. So they lock their door in their home and did their attempt at the time when they know there was nobody at home. So that would be a higher score and indicates that the patient was more serious in their suicidal attempt. Acting to get help during or after the attempt. So a person after the attempt just suffered some injury and contacted someone to help them. So their score would be lower than somebody who did not contact anyone, who was found in their attempt, which required a higher score. Final acts or anticipation of death. So prior to the attempt, they would have made plans, made a will, already organized their things, made definite plans of how they would want to their personal belongings to be dealt with after they have passed away. Indicates that the patient was very serious in their suicidal attempt, which is more or less similar to active preparation of the attempt. So they made extensive. If they made no attempt at all, they just woke up one day, took a knife, and tried to cut themselves with no preparation. It's more impulsive. But if they already planned very meticulously the date, the time, the place, then it's a more serious attempt. As well as the absence or presence of a suicide note also signals the severity of the intention. Overt communication or intent. So if they told straight out and out that they're going to do it, again, anyone who said it, you must consider them seriously. You shouldn't just think, oh, they're just trying to get attention. Most of the time, when people say that they want to commit suicide, they mean it. Probably they haven't planned yet or want to do it or anytime soon, but you have to take it seriously. And then as well as alleged purpose or intent. So if it's to manipulate environment to get attention or as revenge, spiteful towards somebody, then it's less likely they will tend to suicide. However, if it's to escape or to solve their problems, then it's more likely that the suicide intention was real. As well as expectation of fatality. So this is the patient's own subjective expectations. They thought that the act would commit suicide, even though if it's something like they cut their wrist, even though most of the time people won't succumb to death from that, if the person believes that that was enough to commit suicide, then it would have been a higher score because the patient themselves thought it was probable. Okay. However, the conception of matters lethality. So if the patient thought, okay, if I took like 50 milligrams of morphine, I thought I wouldn't die. But as us, we know as clinicians, that would have been a morphine overdose. So that means the lethality was equal or exceeded what she thought would have been lethal. Then, of course, the seriousness of attempt is a patient's subjective feeling of how serious they will attempt to commit suicide, as well as the attitude towards living or dying. The conception of medical rescuability. Patient was, whether it was certain or not certain, with medical attention was patient able to be revived, as well as the degree of premeditation. So if it's there was no premeditation, just patient impulsively did it, it would be a lower score. However, if they contemplated it for 3 hours or more before the attempt, then it should be taken seriously. So based on this scoring, you can stratify to low, medium, or high. So with low risk, may be able to send home with probably a psychiatry outpatient TCA. Medium risk and high and above maybe will require a formal psychiatric assessment. But as we said, all of this is just an assessment tool. In the end, the best thing you can do is your own clinical judgment. If you're not sure, uncertain how high risk this patient is, an immediate psychiatry referral is always preferred. Okay, that's all. These are my references. Hope I made it in time, and thank you. If any questions, please drop it off in the chat.
If there are any questions, please don't hesitate to leave them in the chat.
Okay, there's one question, Karinisa. Dr. Karinisa, if there's someone with a weapon, what should we do? So a person who is aggressive, who's currently in a weapon, first we should consider the situation. If the patient is, like for example, if in an ED, a busy ED crowded room, and you're the attending doctor, it's best not to be a hero and try to grab the weapon and tackle a patient down. It's always best to step away, step back, call for help. If possible, ensure anyone, any patient or any people around them, surrounding, try to evacuate from premises and not to engage directly in with the patient as of yet. Maybe this will, the first step always when I'm dealing with an aggressive patient is to try to verbally de-escalate. So try to calm the patient down, ask the patient why is he behaving like this, what is his reason for it, what is his needs, see if we can meet them. Maybe they say, oh, I'm aggressive because I've been waiting here for 5 hours, I have not seen a doctor, I want to see a doctor now. Then if that's the case, then you have to assure them, okay, we'll try to see a doctor. We'll let the doctor see you now. And in the same time, if the patient is still cooperative, then we can try to offer any oral sedative medication to just help calm the patient's mood down. But again, if patient will already have a weapon, always call for help. Help being the security, the hospital security, because they will have the better training to, if the patient is physically violent, to help engage the patient. Okay, if there's no other questions, pass it back on to moderator, Dr. Lily. Thank you.
Okay, thank you, Dr. Arun, for the wonderful and thorough deliverance. Oh, we have actually one more question. Dr. Arun, if you may.
Okay, so Dr. Vivi, the question is, if a non-patient aggressive in the hospital area, what should I do? Call PS5 stat? Okay, so if a non-patient, meaning not someone who is currently being treated under the healthcare, the hospital or clinic, it's not the right thing to do to call PS5 stat. Uh, we are not the superheroes to come and to treat everyone who is acting aggressive or violent. No, that's not right. Of course, something needs to be done, but like I said, it has to be involving the security of the hospital, the security personnel. They are more properly trained to deal with these kind of situations. If after controlling the situation, they're able to de-escalate or restrain the patient, the person, and then subsequently find out that, oh, okay, this person actually has some medical reason for him being this way, maybe some delirium curve, or maybe unlike PS5 patient, then maybe the proper channel to bring to ED for further workup and assessment, and then later may call PS5. So I hope there's no misconception thinking, okay, oh, it goes to suicidal patient as well. If a patient is suicidal, it's not the right thing to do to call the PS5 clinic. Oh, my friend is suicidal. I want to bring to PSY clinic right now. That's not the right thing to do. It's not right from legal's perspective as well. We're not the authority to save everyone who is suicidal. The proper channel would for them to bring to the nearest healthcare facility to be assessed properly by the doctor, and then from there on we'll see the progress. If he requires a urgent psychiatric referral assessment, then of course by all means please send it to ED. We'll be more than happy to treat and assess the patient. But just re-emphasis, any violent, any suicidal patient, it's not It's not the right thing to do to just, okay, psychiatric's problem. All right. Okay, another question.
Last question, okay?
All right. Is a patient who is saying he or she wants to die and is practicing self-harm considered suicidal? Okay. So that comes again to our assessment and maybe regarding our previous slide with the back suicidal index. So this is a gray area. A patient says that she wants to die and is practicing self-harm considered suicidal. So can we dismiss this patient saying, oh no, this is something that just wants to get attention? No, we cannot. We cannot do that. We have to probe further and ask, as what I shared previously, one by one, what exactly is his his methods, the reason, his preparation, how premeditated it is, its intention. Was it specifically to release stress or to end his life? Was it to escape his problems or in an act of defiance to whatever authority figure he's having some kind of conflict with? All this must be probed individually, carefully, one by one, and if can, systematically. Only by doing this, when you get a whole picture of the person's situation, can you make any accurate or justified assessment. Because in the end of the day, whatever assessment tools you use, in the end of the day, it's your personal judgment, clinical judgment of how severe the suicidal intention of the patient is. And if any doubts, it's best not to gamble with fate. There's an urgent psychiatry referral will be more than appropriate to be done, more than indicated. Okay. Right.
Okay, I think that sums up Arun's slides perfectly. And the most important thing is to remember to not be judgmental when you come across these kind of patients. Always try to understand their needs and why they're acting that way, okay? Take a bit of time to understand why they're acting that way. Okay, so as the saying goes, to every beginning, there is an end. We have reached the end of our course. We'd like to extend our deepest gratitude to all of our incredible presenters, Dr. Allen, Dr. Chong Wei Wei, Dr. Simon Wong, Dr. Farhan, and of course, Dr. Arun, for the extensive knowledge that they have shared with us throughout the day. I'd also like to express our thanks as well to our dear participants who had stayed loyally with us till the end. We hope this course succeeded in providing the extra needed knowledge that will allow early detection and intervention of mental illnesses. May what we have learned today be applied for future practices. So on behalf of Hospital Tawau Psychiatric Department, I would like to extend my deepest apologies for any mistakes or inconveniences that may have occurred from our side. Before we disperse for the day, allow me to remind everyone to scan their attendance for the QR code presented. Recordings and slides and e-certificates will be shared to our participants via email. We would also greatly appreciate feedback from you all regarding our course for future improvement. If there are any further questions, you are always welcome to contact us via WhatsApp group or email. Thank you again for joining us today at the Fundamentals of Psychiatry, a refresher course. We hope to see you again soon.